Good afternoon. Welcome to the YWCA's Talk on Health. Today, we are going to be talking about type 1 diabetes, and it promises to be a treat. This conversation, or these series of conversations, were developed by the Lower Cape Fear YWCA and the alumni chapter of Delta Sigma Theta Incorporated of Wilmington. We thank both of our wonderful sponsors. I would like to begin with the land acknowledgement from the YWCA. The YWCA of Lower Cape Fear serves the people located within the Lower Cape Fear region. This land once thrived with life from the indigenous peoples known today as the Cape Fear Indians and the Waccamaw Siouan Indian people, living in established settlements along the Cape Fear River and Lake Waccamaw, along with many other established sites in the region. We need to protect and honor the history of these places. Indigenous peoples are not relics of the past. They are still here, continuing to demonstrate their talents and gifts amidst the backdrop of ongoing colonialism and oppression. They are worth celebrating. We hope our land acknowledgement statement will inspire others to stand with us in solidarity with Native nations. Thank you very much. We have three wonderful panelists here today. We have Dr. Oshinkoya, who is an internist and a geriatrician who is joining us. And we have a nurse, I apologize. We have a nutritionist, Rachel Bell, who is here joining us, as well as another nutritionist, Heidi Kaufman. And we are so lucky to have Belva Jenkins from the YWCA Lower Cape Fear. She is the CEO, and this is a topic that's near and dear to her heart, but I'll let her tell you more about why that's so. So we'll start out with Dr. Oshinkoya introducing himself.
Hello, everyone. Abayomi Oshinkoya. I graduated from College of Medicine, University of Ibadan, Nigeria, and I did my internship residency at Columbia University, College of Physician and Surgeon at Harlem Hospital. I did my fellowship in geriatrics at St. John's Hospital under New York Medical College. I'm a former associate professor of geriatric medicine, and currently I'm the medical director for East Carolina Medical Associates in Jacksonville, North Carolina. Thank you.
Thank you very much. Rachel, could you please introduce yourself?
Yes, my name is Rachel Bell, and I'm a registered dietitian at Summerfield Custom Wellness here in Wilmington, North Carolina. And I'm originally from Raleigh, North Carolina, and I did my undergraduate at NC State and my graduate degree at Meredith College. And I'm happy to be joining today. Thank you.
Thank you.
Happy birthday.
Heidi, could you please introduce yourself?
Yes, my name is Heidi Kaufman, and I did my master's degree in public health nutrition at Case Western Reserve University in Cleveland, Ohio. I have been working as a nutritionist and a diabetes educator for the last 25 years in New Hanover County. I worked with the hospital, New Hanover Regional Medical Center, Wilmington Health, and now at Cellicare Research.
Thank you. And last but not least, Ms. Belva Jenkins, could you please introduce yourself?
Good afternoon, everyone. I'm Belva Jenkins, and I'm the CEO of the YWCA. And my purpose for being on this panel today is because I am a type 1 diabetic.
Thank you very much. And I am Dr. Lakeisha Jarrett. I'm a family medicine physician who works with Wilmington Health. I love the opportunity to moderate these talks and to get this information out to the community. Please join in, ask us questions, put them in the chat, and I hope you learned something today. We'll start out with a very direct question. What is diabetes? And any panelist can chime in and answer that.
Well, from the medical perspective, diabetes basically is a manifestation of dysfunctional metabolic state for glucose. What we commonly see as a high glucose level is just a manifestation of the disease. And other things that are symptom-wise that we see along with it will be things like feeling thirsty all the time, drinking too much water, going to the toilet to pee more often, unexplained weight loss. These are some of the symptoms that you will see with diabetes. At times, we may also see some visual complaints, blurry visions, numbness in extremities and things like that. So if you look at diabetes from the metabolic standpoint, it's a dysfunction of glucose metabolism, basically.
Thank you very much, and for adding some of the symptoms that people see. Velva, would you mind talking about what it was like when you got diagnosed?
Sure. Well, I started having vision problems was my big thing. I really don't have a weight problem. Well, not under the situation where will be contributed to your diabetes. I really do have a weight problem, but not like that. And but my vision was getting very poor. I would walk into the grocery store and I couldn't see the directions or directory for what's on the aisles of the grocery store from a distance. And I do my eye exams very regularly. My prescription was up to date. And that was my first sign. And then it just kept getting worse. And I just felt tired all the time. I couldn't drive without getting very sleepy, couldn't sit for a long time. And just my energy was getting very, very depleted. So I went to the doctor and had a very high glucose reading when they checked me. It was close to 500. So they put me on oral medications very quickly. Didn't work, didn't help very much, but we stuck with it for about 2 years to try to keep it down and watch my carbs and counting carbs, which was very new to me and was very difficult to do. But I did get a hang of it, but it still wasn't really helping my numbers.
Can you tell me what time frame it was between when you started having vision problems and when you finally decided I have to go to the doctor?
Mm-hmm. Well, it was late in life. I was like in my 50s when this all started happening, with the vision and the tiredness and just the energy being depleted. And I was pretty active, not as physically active as one should be, you know, exercising every day, but I wasn't a person that sit a lot. I was moving about, working in the garden and that kind of thing. So I just didn't really understand. And it took about 2 more years for them to do, and I'm sure our doc physician that's on the call today could talk about the testing that said it doesn't look like type 2 since you're not responding to the oral medications. So that's when they put me on insulin. And that is what definitely started bringing my numbers back to the place where they would like to see them. And then I had to learn about the A1C, you know, I was thinking I'm doing good. And 3 months later, I get an A1C and it may not be where it should be. It could be still over 8 something. And you're saying, but I had a lot of low numbers, but that wasn't it. And you probably hear me beeping now. That's my CGM.
Well, Dr. Oceankoya, could you tell us the difference between type 1 and type 2 diabetes and talk a little bit about how to differentiate that with testing?
Okay.
Since Velva's already introduced that.
Basically, diabetes can be seen as either a deficiency in terms of insulin production or a resistance of our tissue, our body to insulin. So the type 1 diabetes are commonly people that have insufficient secretion of insulin. They are deficient of insulin. What is causing that in terms of etiology can be autoimmune disease, just your body reacting and destroying your islet cells that produce the insulin. It could be from viral infection, from injury or trauma, or environmental damage to the pancreatic cells that produce insulin. These are the people that are commonly called type 1 diabetics. Type 2 diabetics, in most cases, they are still making insulin, but they have what we call end organ resistance, whereby their body is not utilizing the insulin in a proper way to transport glucose from the bloodstream into the blood cell, where it is used as energy. In terms of testing, the first thing is to have hyperglycemia, that kind of put you in the range of diabetes. Then to further find out, do you still make insulin at all? And to do that, we can do what we call the C-peptide and the insulin level in the blood, which can show you if you're still making insulin or not. But if you are going more deeply to sophisticated testing for type 1 diabetes, then you may need to be doing things like genetic testing, antibody testing, to see what kind of antibodies actually destroy the beta islet cells. So in terms of differentiating between the two, it's more of seeing if the patient is still making insulin at all. And that can easily be done by doing the C-peptide protein, level or the insulin level in the bloodstream.
Thank you very much. We're going to come back and ask a couple of more questions about that, but I want to talk about, is there a way, like when you get diagnosed with diabetes, can your proper diet change it? And maybe Rachel can chime in on that a little bit, if it's type 1 diabetes.
Yeah, totally. So when you have type 1 diabetes or diabetes in general, diet plays a huge role in the progression of the disease and the management. When it's a type 1 diabetes, unfortunately, there's no cure that we know of. It's a chronic lifelong condition. So diet at that point is kind of managing symptoms and quality of life and trying to reduce complications further by, I can talk about how we do that. Type 2 diabetes, so if it's especially a new diagnosis and they found out recently, there are ways that it can be reversed or definitely have normal glucose levels depending on how recent the diagnosis is through diet changes. Because usually it is a result of lifestyle and eating factors that have caused that in the first place, the insulin resistance. So with all different types of diabetes, it's obviously important to watch carbs because carbs get broken down. When we eat carbs, they get broken down into glucose, which then enters our bloodstream, and glucose is our main energy source. So we always want to be cognizant of how much carbs that we have and how we consume them. But for type 1 diabetes in particular, diabetics, it's really important to know how much carbs you're taking in, as that directly determines how much insulin that you need to give yourself. So type 1 diabetes, it's a lot more important to know exactly how much carbs that you're eating. Type 2 diabetes can be more of a, there's a range that you can stick in within how many grams of carbs that you're having per meal. And then with type 1 diabetes, it's also really important to manage timing of meals. Having more consistent meals throughout the day, time with your insulin and medication is really important to prevent, as they're at a higher risk for low blood sugar if you skip or go too long between meals, and versus people with type 2 diabetes where they have still producing some insulin, they sometimes have a little bit more, they can handle longer periods of time between meals a little bit better. But we want to, always have healthier carb sources that are richer in fiber. So like starchy vegetables, whole grains, beans, things like that are going to help promote better blood sugar control, and adequate protein sources from lean things like poultry and fish and plant-based sources paired with your carbs, and then obviously an abundance of color through vegetables and moderation of fruit that are going to give us all those vitamins and minerals and healthy phytochemicals that reduce complications later on in life.
So counting carbs seems like that's a lot to learn for an average person. How long does it take generally for patients to learn how to count carbs and and how much insulin to give themselves with type 1?
Yeah, so it can sometimes take months for people to kind of get the hang of it, where they can, look at it, either look at a package if it's got a nutrition label on there, that can be helpful. Looking at the amount of carbs that are total carbohydrates on that label. And then there's ways to kind of, I like to say, guesstimate, using we like to count in servings of 15 grams of carbs equals 1 unit or 1 serving of carbs. So between different types of carb foods, how much you give yourself, of that food to equal about 15 grams of carbs, that each of those equals kind of 1 unit of insulin or so. So it can take a little while to kind of learn, but we've got a lot of like handouts and charts and things that are good reference tools that people can put, keep in their kitchen or where they prepare their foods and things like that, but and measuring tools and visual aids, but it could definitely take some time to learn that, definitely.
What about the risk of your sugar dropping too low or hypoglycemia? Does that happen a lot when type 1 diabetics are learning how to use insulin?
There's definitely an increased risk for that, definitely, as you're trying to navigate how much carbs that you're taking and then just how much insulin to pair with that. It definitely can be a higher risk compared to those with type 2 diabetes. When the blood sugar is going too low, knowing your body and knowing early warning signs of that can be very helpful for people with diabetes in general to kind of know how much to give themselves. Fortunately, there's definitely like backups and things like fruit juice and even glucose tablets and things that we can do to quickly raise it back up if that is the case. But usually with working under a dietitian or a nutritionist or diabetes educator, they can help structure help you structure your snacks and meals to prevent that. But low blood sugar can definitely cause symptoms like dizziness, kind of like your head is ringing, fogginess, you feel very low energy, weak, and if it's too low, it can cause people to pass out or even have seizures, things like that.
I also understand that if it gets too low, you could also have a little confusion, not knowing what direction to go or whatever. That's when it's dangerous low. But I have found that it was difficult to find that right pairing, how many carbs will take for the insulin to act against. For an example, like you said, Rachel, that 15 is normally the carb that's equal to 1 unit. Well, it may be 12 for some people for 1 unit of insulin, or 10 or 9. So that means for every 9 carbs I eat, I need 1 unit of insulin to control that. So it depends on the person and how much insulin their body needs to be giving out.
We often start out with that 15-to-1 ratio, and then that will change over time based on what's actually happening. So like you said, one may start out with 15-to-1, but then it ends up being 9-to-1 or 6-to-1. And oftentimes with the older person who has type 1, they may have developed a little bit of insulin resistance as well. And so their needs are going to be a little higher than a younger person might be. One thing I want to mention too is that oftentimes people are on insulin pumps, which can actually be programmed to have that set. So you can have that ratio set where you don't have to keep figuring it out yourself. And then you just know how much to give yourself for a certain amount of carb that you're eating. But you do need to know how much carbohydrate you're taking in, and that's sometimes a little difficult.
Also, there is what we commonly refer to individual insulin sensitivity. So some patients may respond at a rate of 1 to 15, some may be at a rate of 1 to 9, 1 to 16. It all depends, and you have to individualize. I mean, before we kind of give the same treatment to everybody, but in recent time, you have to individualize our diabetic management. That's the main goal now, to really see what the patient is actually in need of in terms of insulin dosing and be able to kind of manage that for them.
So, well, can I ask you what what made the biggest difference for you when you were figuring that out? Did you have access to a nutritionist all the time? Or could you contact your doctor or your doctor's nurse? How did you navigate that?
Well, I'm a patient at Wilmington Health, and the endocrinologist there has a team of the diabetic educator and also somebody that specializes in insulin pumps and also the continuous glucose monitor. And that was the easiest way, is just going to the sessions on nutrition and also understand how the glucose and the monitoring system would be helpful and beneficial to me. Not being a young learner, I needed all the help I could get. So the insulin pump that I have is not wireless. It has a tubing, but it does talk to my continuous glucose monitor. So if it sees me doing, especially if I haven't given myself more insulin than I should have given myself, like for an example, if I eat a bagel for breakfast and it's 35 carbs, and I gave myself, for some reason, 45 carbs because I was going to drink a cup of coffee with a lot of cream in it. And then I decided not to drink the coffee. So I've got more insulin in my body than I needed. But if my glucose, continuous glucose monitors see that I'm falling, that I'm dropping really fast, it will shut my insulin off, which is in the background, giving me a little bit of insulin all the time. And then that'll cut it off, and that will slow my process of dropping too low. Sometime I may go low anyway, but the majority of the time it will stabilize it. So that has been a huge help for me. Had a huge correction of my A1C because of those two things working together.
So you haven't had this the entire time that you've had diabetes, is that correct?
No, I've been on the pump for 3 years.
Okay. And then how long have they been able to communicate with each other?
The whole
Was
3
that
years.
the entire time that you've been on the pump?
Yes, I went on the one. I chose, it's the Dexcom and also the, oh, now I'm going to forget the name of it. Can't remember the name of my pump now. But they talk to each other. It'll come to me in a minute. I'm so sorry.
It's okay.
Okay. So that was life-changing for you, I'm sure, like you said, right?
Mhm.
Absolutely. Dr. Oshinkoya, can you talk about what triggers type 1 diabetes? Like, why would Velva get type 1 diabetes as an adult?
As an adult, okay. Basically, as I mentioned earlier, type 1 diabetes, basically you are dealing with insulin insufficiency or deficiency because the beta cells are not making enough insulin for you. So in most cases, type 1 diabetes you see in children. You have a bimodal peak of it between 4 and 7 and between 10 and 14 years of age. But as we know, about 25% of people with type 1 diabetes are in adults. So really, you may be diagnosed as an adult with type 1 diabetes. And what that means is that you are truly not making insulin, or you are deficient of insulin. That is why when people come in with diabetes as an adult, we will commonly presume that they're type 2 diabetes, study them on oral anti-diabetic medication, and they are failing. They're not responding to it. And that is a very highlight that we should further look into classifying their diabetes. So in that instances, we may do the C-peptide, may do insulin level, we may do other tests in terms of antibodies to beta cells, and that may expose why they are actually not type 2, but they're type 1. So in older age, in her own case, she may have what we call type 1 diabetes that are more of beta cell phenotype. The beta cell phenotype simply means that your beta cells are not performing at par. You still have the cells, they are making insulin, And in your younger years, you may have hyperglycemia and they give you extra insulin. It's corrected the situation for you. So you have what you call honeymoon period, where you are still able to manage yourself either because of your weight, your diet, lifestyle changes, more exercise, things like that. But as you get older and you have less and less of the beta cells, they become more exposed that you are truly deficient of insulin. And at that time, you are then being diagnosed as type 1 diabetes. It's different from type 2, which is you are making insulin, but you do have end organ resistance or end organ failure, whereby your tissue, which is more of the muscle, are not being helped in terms of transporting sugar or glucose from your bloodstream into your cells to make energy. That is type 2 diabetes. And that you can manage either with GLP-1, SGLT2, you can use oral, you can use insulin if it's necessary. So that is how you can make that differentiation. It's not uncommon. Basically, it's not uncommon to diagnose older adults or younger adults with type 2 diabetes, type 1 diabetes, because at that time, you truly have insulin insufficiency or deficiency of insulin.
Thank you. Can a person with type 1 diabetes live a normal life?
Yeah, they can live a normal life. It's more of understanding the disease. It's understanding the disease. And what I always tell my own patient is that when you have diabetes, it's like you have to understand the palm of your hand. You have to do things the right way. Like the dietitian said, diet, lifestyle changes, they are very difficult things to do. But once you understand the disease, that these are things that you have to comply with, then your medical intervention in terms of treatment becomes more amenable. Because no matter how much insulin we are giving you, either through continuous insulin monitoring or system, or through self-monitored, self-administration of insulin, no matter how much insulin we are giving you, if your lifestyle is not corrected in terms of your food intake, the type of food, the amount of food, how you eat, and things like that, how much processed food you have. The less processed food, the more natural things, the more high fiber content of your food, and becoming more active in terms of not necessarily going to the gym and buffing up, but just going walking. Just put that as a routine in your lifestyle, like an hour of walk, maybe 5 times a week. That may just be enough. And then we look at how we manage your insulin. The issue of insulin sensitivity comes to play when patients with diabetes have variation in their weight, variation in their food intake, variation in their activities, and things so that kind of reduce or increase the demand for insulin. So that is where the issue of using continuous glucose monitoring, insulin pump, they have to have a good understanding of what this is all about. Like Velva endocrinologist practice, they have a dietitian, they have insulin specialists in terms of the monitoring of the insulin pump. So patients are going to be placed on insulin pump needs to have a full understanding of how that mechanism works, what they have to do to avoid hypoglycemia, those kind of things will help them a lot.
Can people with type 1 diabetes consume any alcohol at all?
Yes, they can. They definitely can. It's important though to know when you consume alcohol and what types. So usually moderate consumption of alcohol, which tends to be, 1 to 3 drinks can actually raise blood sugar levels. And then once you start getting excessive, actually, usually over 3 drinks when one sitting or one evening or whenever you're drinking it, can actually cause a steep decline and increase risk for low blood sugar. So there's a couple things you can do to safely drink alcohol. So number 1 is always consume it either on a full stomach or with food. Because when you have food, especially protein in your stomach, that's going to help blood sugar kind of rise more slowly and fall more slowly. So on a full stomach with food, and then just being mindful of the carb or sugar content of your alcoholic drinks. So trying to choose alcoholic drinks that are a little bit lower in sugar or carbs. So that would maybe be some dry or red wine, liquor, or champagne. Those are all kind of lower carb alcoholic drinks. But if you know that you are going to have something that's a little bit more sugary, knowing how much is in there and then appropriately dosing your insulin.
Dr. Jared, I'd like to comment on the question about normal lifestyle for a diabetic type 1. I find that it's a little bit more, your life is more controlled because you have to be concerned about their diet. You also have to be concerned about where you are with your numbers. Are you rising? Are you falling? You also have to be concerned about the proper time to give your insulin. So it's not a minute of the day that I'm not thinking about diabetes or giving myself my medication. So if I had one thing to say that bothers me, it's because it's always on my mind. It's always controlling my day. When I wake up, I have to find out where I am with my numbers. Before I eat, I have to find out where I am with my numbers. Before I go to bed, I have to check to see where I am. So you are always consumed or concerned about diabetes as a type 1.
Is that even with the CGM, the continuous glucose monitor?
It
You
does.
still feel that way?
It does, because not as much because it does alert you, but you still have to pay attention to it. I said, you heard me beeping a few minutes ago. It's a T-Slim pump that I have. When it's beeping, it's because I just ate something. And so it was letting me know that I was rising. Although it's going to help control it, it's either slowing my insulin levels down automatically, but it still alerts me that I am rising. So that is, it's always there. It's always on your mind.
Yeah, Velva, I can understand your perspective on that. But when we are talking about living a normal life, you are a CEO of a corporation. So I'm saying, so you're still productive. You're still living a full life. So that is what I'm getting at in terms of saying that I can still live a normal life. But to get to living that, being able to achieve that, you have to pay attention to what you're doing. I mean, I've seen younger folks. I mean, I end up in geriatrics, I will tell you this, because I did a research as a resident in terms of who is actually interested in their health and who is not. The younger folks will come in and just, they're nonchalant about the whole thing. Whereas we are dealing with people 50 and over, they're asking you questions. What do I need to do? What is going on with me? So I'm saying, so they have more interest in it. And what I'm getting at with diabetes, particularly type 1, is that the sooner you get interested in what is going on with you, the more likely you will have less of the chronic long-term effects of diabetes. Because if you don't pay attention to it as a young folk, I mean, I've seen patients that will come in eating pizza, a whole 12 slices of pizza, or just eating irrationally because they're on insulin pump. And they feel that once I'm on insulin pump, I'm fine, which is not true. So no matter how much insulin we are giving to you, either you are directly administering it, you are doing real-time check, or you are doing intermittent checks, it doesn't matter. You have to have a good understanding of what you are dealing with and how to deal with it so you can live a normal life. Yes, it's true that you are preoccupied in terms of what is my sugar before I eat, what is my sugar when I go to work, when I go to sleep. All of that is important. But the central part is to have a good knowledge of it. And if you have a dietitian or a diabetes educator that you're exposed to that can guide you, once you get into that routine, you will see that your sugar will be very well controlled because you understand what you're eating. To a large extent, what you put in your mouth determines a lot of where your sugar is. And once you can control that, you have an understanding of that, it is much better for you. And you can still live a very productive life, because I've seen a lot of people becoming disabled because of type 1 diabetes. Blindness, I mean, amputation, You know, a lot of this, getting on dialysis, all these things are things that we can prevent or we can delay or really push away from us if you can just understand that your diet is central and you must have an active lifestyle. The insulin is what you need, which is being provided. But if you are doing things that are counteractive to that treatment, then you're not going to get the benefit of it. And a lot of the side effects, the chronic complication of diabetes will set in. So for you, I'm happy that at least you have it and you are dealing with it. You are still living a very productive life. And that is what I want the younger folks to start looking at, that the more you get involved with your treatment and with how you deal with life, how you eat and things like that, the better they will be.
Dr. Oceankoya, you touched on this, but can you talk about some of the sequelae of diabetes, like dialysis and amputations, and why that happens?
Well, basically, we have micro and we have macro vascular complications of diabetes. And if you start from the heart, you have cardiovascular events, which are more of the big vessel intervention, atherosclerosis, coronary artery disease, heart attack, strokes. Those are the cardiovascular complications from diabetes. Peripheral vascular disease can lead to tissue damage or death and causing amputation. You know, you can look at the eyes. You know, you can have commonly retinopathy, which is there is. I always tell my friends that it's like spring on the retina when you have diabetes. The blood vessels are dividing radically. And there is a particular spot that's called the fovea. If the blood vessel should cross that spot, you go blind. So it is very important for a diabetic to see the eye doctor at least once every year, for them to have a dilated eye exam to look over the retina, make sure there is no bleeding or leakage of blood vessels and things that they can easily take care of if it's identified on time. So blindness is part of that from the retinopathy. They are also at risk of cataract because of the high blood sugar. They are at risk of glaucoma because of high blood pressure, pressure in the eye. When you look at the kidneys, they are at risk of nephropathy and ending up on dialysis. You know, if you look at the nervous system also, the numbness, the tingling, they are from high blood sugar damage to the vascular capillary beds. And as time goes on, they have a lot of neuropathy that they may even have injury to their foot or to their skin without them knowing that there's injury there. So you have foot that can cause foot ulcers in diabetes. If it's not taken care of, it causes amputation. That's a complication also for them. So a lot of things, particularly when you're talking about pregnancy with type 1 diabetes, it's a very, very tough topic. I mean, you have to start from the preconceptual stage. Every female of childbearing age with type 1 diabetes must be on contraception. And if they plan to get pregnant, that must be in consultation with that group that can take care of them, you know, to have their blood sugar under control before conceiving, and to maintain that blood sugar under control during pregnancy and even after pregnancy. You know, things like endocrinologists, fetal maternal specialists, the dietitian, the diabetic educator has to come as a multi-specialty group to really take care of that particular patient. You know, you can still use insulin in pregnancy. You can still use continuous glucose monitoring in different ways in pregnancy, but they have to be more taken care of even before they get pregnant. They have to understand what is necessary to be done in terms of having their hemoglobin A1C under control, their blood sugar under control, doing their screening in terms of diet, doing their screening in terms of other complications or comorbidities of diabetes, high cholesterol, high blood pressure. You know, they have to check all these other things before they get pregnant. So really, type 1 diabetes with pregnancy is a very, I would say, complicated case, but needs a comprehensive care team, and needs to be started pre-conception and can go as far as post-conception to prevent other complications of pregnancy. They have more of fetal loss, premature birth, preeclampsia. You have other issues that can come up with pregnancy in terms of our diabetes management.
Rachel, can you talk about how you counsel with women who are pregnant when they have type 1 diabetes?
Yeah, definitely. So it's definitely possible to have a safe and healthy pregnancy if, especially if you are very good about monitoring, you know, the ropes before you get pregnant, and you're good at checking, because monitoring your glucose is the most important thing you can do when you have diabetes when you're pregnant, because as the fetus is growing, they also need glucose to help them grow for energy. So there's a risk of lower, there's always a risk of lower blood sugar with type 1 diabetes, so even more of a risk. And so sometimes it looks like having a little bit of extra carbs to account for, especially usually in the first trimester, they don't need too much of a dietary change, just making sure they're monitoring their glucose. And then as the baby is growing in size and more tissues are being developed, they may need to consume a little bit more carbs to account for that, to make sure their own blood sugar doesn't go too low. So it's still a lot of counting, but frequent monitoring. And if you usually they have a good system in place when it comes to how much insulin to give themselves, but we do see like a little bit of an increase in glucose needs to help offset that disposition for low blood sugar.
Do you see women more during their pregnancies than you would normally see them for type 1 diabetes?
It depends. I know that, it can be a mix. I think that there's definitely some patients who come to me who just aren't pregnant and they just don't know, how to balance their blood sugar. So I see a lot of that. But then, if they've been educated elsewhere, they're otherwise healthy, sometimes they do see a dietitian because they are concerned, now they really want to make sure that everything is okay as they're growing a child. So we do see a mix of both, of some women coming to us when they are, growing a child, just because they want to prevent any complications. And then there are some adjustments, and obviously outside of diabetes, making sure that they have all the nutrients that they need depending on the fetal stage of development, just making sure that they're having everything a well-balanced diet. We definitely see an increase in pregnant women just wanting to make sure they're doing everything right.
Belva, I was going to ask you earlier if there's any particular thing that is harder for you, because you talked about how you're always thinking about your blood sugars and your insulin levels. So is traveling a big difficult thing for you, or what do you think that just takes a lot of planning for you?
It really doesn't. It doesn't interrupt my normal activities, as the doctor was saying. I just have to be mindful that I have to be concerned or be aware of what I'm eating, about my carbs and that kind of thing. But traveling is fine. I have a note from my physician. If I go to the airport and they find there's something on my side, I just pull out my sheet. I'm not patted down or scanned hard. And sometimes, they do. If they see something sticking out on my side or on my arm, they may not be aware that it's a medical device and think something else different. But my physician has given me the paperwork that I use when I travel. That's it. And with the insulin pump, it makes it much, much easier for me to be able to travel and be more flexible, because my insulin is on board of my pump. And if I fill it up, it's there for 3 days. I'm good. I just pack extra supplies in case something happens, something malfunction. But other than that, it's good. I keep things in my purse to use the regular glucose monitor, not the continuous, in case something happens to my Dexcom. So I've learned how to be prepared and have my backups. And the only other thing, Dr. Jared, I would like to say, if I exercise or work real hard in the yard, physical activities, I will have a change in my glucose. I will use, it will go lower for me. So I have to either change my settings or be mindful to have, a snack or something when I'm working or working out or in the yard.
All right, thank you very much. Dr. Oceanquaya, you had mentioned something earlier, and I wanted to come back and ask you about the microvascular. What does that mean? The microvascular, macrovascular complications? Because we have the community listening, so I just want to make sure they understand what you're talking about.
Okay, when we're talking about micro, which is MICRO, we're talking about the capillaries. When we're talking about macro, we're talking about the bigger blood vessels, like the arteries and things like that. And the macrovascular, which is the bigger vessel complications, are most of what I mentioned to you, which has to do with the heart in terms of the coronary arteries being damaged with plaques and causing heart attacks, stroke, things like the eyes, the retinopathy is a macrovascular complication. Things like the kidney packing up is a macrovascular complication. But when you're talking about peripheral neuropathy, which is nerve damage, that is talking about the capillaries that supplies the nerves endings. And that is where you have the numbness in the fingers and the toes. The neuropathy can come from that, yes.
Velva, you had mentioned earlier about the A1C. How often do you get your A1C checked, and what is your goal for the A1C? And then I'm going to get Dr. Oceanquaya to tell us exactly what an A1C is.
I am at my endocrinologist every 3 months. I do not miss. I am there. He's checking my toes, my foot, my throat, and my all of that, and my A1C, and talking to me about my physical activity and my health overall. I go every 3 months, and I would love, of course, to get it under at the 6th level, but my endocrinologist is happy with it being at 7. So right now I'm at 7.1. So I'm thrilled, and that's probably the lowest it's been. It's that way because of the pump in the glucose monitor. It keeps me mindful. It keeps me reminded of what I need to be doing, because I was always over 8 until then. So I'm happy, and I got a feeling when I go back, it'll be lower.
So all of this new treatment, all of these new treatment methods have really made a difference in other ways other than just making it easier for you to not think about it.
Improving my health, yes.
Improving your health overall. Okay, Dr. Oceanquaya, can you tell us about the A1C?
A1C basically is a measure of glucose attachment to the red blood cells in the body. There's a receptor there that the higher your glucose level is, those receptors get kind of taken over. And it's a reflection of the lifespan of your red blood cells. So in some patients, like people with sickle cell anemia, thalassemia, even pregnancy, where you have a very high turnover of the hemoglobin A1C, it may be unusually or deceptively lower than necessary. The intent of checking every 3 or 4 months is because the lifespan of red blood cells is about 90 to 120 days. And that is how we measure the A1C. Now, in terms of the goal, the ADA goal is about 7%, which is the American Diabetic Association. For the American Academy of Clinical Endocrinologists, they set their own goal at about 6.5. But more importantly is to individualize the hemoglobin A1C, because in elderly patients with other chronic conditions, you don't want to make it so as low as 7. So 7.5, 7.3 is still acceptable. If they are younger folks, more healthier people, I want to get them closer to 6.5. Pregnancy-wise, we want to get at about 6%. So that is how we kind of look at the hemoglobin A1C. In some places, you may use some other parameters, particularly if you're on the continuous glucose monitoring. You may use their average glucose level. That's about 14 days average. You may use that to kind of direct your management. So hemoglobin A1C is commonly used to adjust management, but you have to know the circumstances. So we are dealing with that, with pregnancy, with hemoglobinopathies like thalassemia, sickle cell disease. If you are dealing with any condition that gives you rapid turnaround of the red blood cells, you may have a erroneous hemoglobin A1C. So you have to be very careful about that.
Interesting. Whenever I send people to specialists, they always want to know what the patient's A1C is when they see them. So, you know, I just want to make a plug for people in the community that have diabetes to know your A1C. Remember what it is, especially if you're going to see a new doctor.
Yeah,
that is really good information for them to have.
Yeah. It's very important. Very, very, very important.
Yes. Yes. So I am going to thank you all very much. Does anyone have anything else that they want to add that they feel like we missed in this conversation, or something you feel like people in the community really need to know about type 1 diabetes?
Dr. Jerry, can we talk just a little, I think we've got a couple of minutes. Can we talk a little bit about what's going on in the latest research?
Oh, absolutely. Yes. Yes. Who wants to speak about that? What's going on with the latest research? I see that that over the past 30 years, there's been a lot that's occurred with treatment. Can someone speak about that? If it's something other than the continuous glucose monitoring that we've talked about.
Well, there is a pancreatic transplant now. You know, at Mayo Clinic in Florida, they actually do this very routinely. And they've reported very successful cases where people are actually, they have become non-diabetic anymore after the transplant. So that is something beyond the continuous glucose monitoring and medication management. There is a lot of selection criteria to qualify for the transplant. There are times that they have to do double transplant of the pancreas and the kidney in patients that have a kidney failure or insufficiency of the kidney. So really, that's something that's on board now that people can also look at.
Very exciting. Velva, was there anything else that you had heard about that you had a question about, or was that the thing that you wanted to talk about?
And I don't know if there's anyone else that could talk about the technology that's available. I have a pump with a tube, and I'm hearing that Omnipod is now coming up with a tubeless. They have a tubeless pump that will also be able to communicate with the CGM. So I didn't know if there was any update on that.
Anyone familiar, have any information on that? I think you might know more than we do about the pumps then.
And the reason I know about the Omnipod, my daughter has the Omnipod, but it does not communicate with her CGM, but she's on a wait list to get the new one that's coming out that will communicate with her CGM and still be tubeless.
Oh, awesome.
Yeah.
Not so much with like, I would say like pumps or devices and things like that, but there is some interesting research coming to, like, you know, we're still trying to figure out why type 1 diabetes occurs specifically, but they're looking a lot at the gut microbial, the gut microflora basically, and seeing, you know, there's association with a lot of kids that had a lot of gastrointestinal diseases from enteroviruses and different things like that, and that disruption of good gut flora may be related to the progression or the development of type 1 diabetes, and certain, or looking at cow's milk and gluten as some correlating factors there too. So, you know, a lot of research is maybe looking back to the diet, seeing if there's also any triggers there too. So.
Thank you very much, Rachel. Okay, so now at the end, I normally give people a minute to leave some parting thought with the community. about type 1 diabetes. So we'll start with Belva and let her make her last statement.
When I first was diagnosed, I felt like my world was over. But having diabetes is not in your world. Like doctors were saying, there is a lot of more productive life left being type 1 or diabetic. You just have to be very concerned about your lifestyle when it comes to food and nutrition and exercise, and making sure that you're attending a physician that will help monitor your medications and you stay on your medications. Especially if you're type 1, it's life. So don't try to avoid taking insulin or stretch insulin. Take it as prescribed, and you can live a very healthy life.
Thank you very much for that. Rachel?
Yeah, so if I had to say anything about, obviously I'm thinking of like a food and nutrition perspective, it's just like get familiar with amounts of carbs within certain foods by reading labels is one of the best ways to kind of, figure out that. And whenever you're having a meal or snack, protein's going to be really important to balance your blood sugar. And there's actually some cool research finding that even the order that you eat foods within the plate can affect blood sugar. So starting with vegetables first that are rich in fiber, and then protein and carbs last within the plate has been shown to sometimes not let that blood sugar rise as high as it would if you ate carbs in isolation or carbs first. So just a little tip there.
That is very interesting. I've never heard that before. But we can all probably benefit from reading labels too, not just diabetics, right?
Yes. And at that point, it's even if you don't have diabetes at all, if anyone's listening to this who doesn't have diabetes, good blood sugar control throughout your life can help prevent onset of type 2 diabetes. And also we're finding blood sugar is the crux of a lot of other chronic diseases too. So good blood sugar control is something that everyone can benefit from regardless of your diagnosis.
And there are some apps out there as well that you can download and be able to find carbs. Also restaurants, they'll give you the information from restaurants. I found those to be very helpful.
Thank you. Heidi, what are your parting words?
Yeah, I just want to put in a plug for the healthy diet in general, and particularly what we call diets that are focused on eating plants more than animals, because we find that helps with all kinds of diseases, including the cardiovascular, macrovascular diseases that afflict people who have type 1 diabetes in particular. And also that when it comes to type 1 diabetes, the key factor is not necessarily eating less carbohydrate, because that's often what people think of, but actually to match the insulin that you need with the carbohydrate you're consuming. And it's just a little bit of a different approach than cutting the carbohydrates out. And many people who don't have diabetes think, oh, well, I'll just stop eating my carbohydrates. Well, for type 1, that won't work. It's not the way to go. And we know that a lot of diets like the keto diets are very popular, not really appropriate at all for a type 1 diabetic, because any form of ketoacidosis is very dangerous for type 1. They're more likely to get acidic as far as their blood is concerned. And so for them, it's really a matter of just making sure that the amount of insulin they're taking matches the carbohydrate they're eating, and that in general, they're eating a healthy diet with a lot of plant foods and not a lot of
Heidi, I'm going to have to interrupt you because they're going to cut off in a minute. And
sorry, I'm done.
Well, my own parting advice is this: knowledge is power. It is only power when you apply it to what is going on with you. So for type 1 diabetes, they need to have a good understanding of their condition and apply those knowledge from the educator, from the dietitian, from their physician to improve their health. The more you understand and the more you apply those knowledge, the better off you are. And a parting information also is that sugar is a chronic inflammatory substance. And if you look at most of our chronic conditions, they are mostly due to chronic inflammation. So less sugar, the better off you are. I tell my patients, anything white off your table, sugar, flour, salt, eat less of those things. Don't take a good food like a chicken breast that's a lean protein supply and coat it with flour and dip it in hot oil. You've destroyed it. So the less of those kind of food that you eat, the better off you are. More natural food, plant food, more protein in your food, more balanced diet in terms of vegetables and fruit and things like that will be good for all of us. Thank you very much for having me.
Thank you so much. I love that parting statement. Knowledge is power. We'll just leave it at that. And thank you all. Thank you, Velva, for joining us at the last minute. Thank you, Rachel, Heidi, Dr. Oshinkoya. You guys were invaluable today.
Thank you.
Thank you.